Hello, good evening. My name's Dr. Gary Howsam and I'm the Vice Chair for External Affairs at the Royal College of General Practitioners. And I'm a GP in Peterborough, which is in the north part of Cambridgeshire. I'd like to welcome you to the third in our series of RCGP Together live discussions, which are really all aimed at giving us the opportunity to speak directly to you, to let you know a little bit about what we've been up to as a college and what we're doing on behalf of you and our patients. We've had one session talking about the use of technology. Last week we talked about mental health, and this week we're talking about the exit from lockdown. We'll be looking at both the theoretical issues that we'll be facing, but also some of those really practical issues that we'll be trying to decipher over the next few weeks as well, as we try and restore a more normal service for our patients. I'd like to thank you all for joining us this evening, and I'd like to thank my panel who will introduce themselves fully. But we've got Lawrence Dorman from the chair of Northern Ireland, and we've got Peter Thule, one of the chairs in Wales, got Mohan, who is one of our patient-centred care leads, and really delighted to welcome a colleague from Spain, Josep, who's in Catalonia at the moment. I'm delighted that you've been able to find the time to join us this evening, Josep. So, as I say, the college has been looking at its strategy for exiting lockdown. It's really important that we keep our patients safe. It's really important that we keep our staff safe, and it's really important that we keep ourselves safe. And we know that people have been working exceedingly hard over the last 2 or 3 months to provide a service. But that service is looking very different to how it was before the lockdown. And as we start to ease the restrictions on movements, both in people's personal lives, but also in the way they're accessing healthcare, we just wanted to bring you a discussion this evening about what we think might be the most pertinent challenges that we're facing. Be absolutely delighted to receive any questions you may have for the panel. You can do that through hashtag RCGP Together Live on social media, or if you log on to the RCGP website members forum, then we've got members of our team scouring both of those, looking for questions which they'll put through to me and then I can put through to our panel. So if we can start off with, I ask Lawrence, if you can introduce yourself, maybe tell folk where you are this evening, what you do as your day job and what your college role is, please.
So good evening, everybody. My name is Dr. Lawrence Dorman, and I'm a GP in Kilkeel. Kilkeel is a small fishing village in the eastern coast of Northern Ireland between the Mourne Mountains and the sea. I'm coming to you tonight from my home in Market Hill, and I'm the chair of the Royal College of GPs in Northern Ireland.
Okay, thank you, Lawrence. So if we can move from Northern Ireland to Wales, and Peter, please.
Hello, yes, I'm a GP in North East Wales between Wrexham and Llangollen, and I also work for Health Education and Improvement Wales. So I've got a role in being an associate dean and helping out with managing GP training. So both roles enjoy very much, and it's interesting seeing the different perspective that we're seeing with COVID across the 4 nations of the UK.
Okay, thank you, Peter. Now, if we jump the channel and we'll go over to European mainland, and Joseph, if you could introduce yourself to us, please.
Thank you. Thank you very much. I'm Joseph Vilaseca. I'm a family doctor, a GP, working in Barcelona City. I'm associated professor in 2 universities, the University of Barcelona and the University of Vic, Central Catalonia, and I'm also the honorary treasurer of WONCA Europe, the European Association of Family Doctors, and I'm delighted to be here. Thank you very much.
Excellent. We're delighted to have you join us this evening as well, so thank you, Joseph. And then Mohan, I think you're in London, is that right?
Yes, good evening, everyone. I'm Mohan. I'm a GP in Merton, so southwest London. I'm also one of the regional clinical leads for person-centred care, of which there's 7 across the UK. And I'm really excited to be here. I really want to see how we can focus on person-centred care to help through the exit of the lockdown. Thank you.
Okay, thank you, man. Thank you for describing what you're hoping to get out of this discussion. Maybe I can just ask the other folk on the panel the same question. So, Lawrence, are there any particular points or topics or areas that you hope come through in the discussion this evening?
Yes, I'm quite interested to hear how people are doing things like chronic disease management at the moment and how they anticipate meeting the demands of things like mental health and so on. One of the problems with chronic disease management, for example, for diabetes, we're looking at which patients are most at risk. While it's easy enough to target maybe the high HbA1cs, what I would be really interested to hear is if anybody has any input on how they would manage a change in HbA1c and how they would record that and measure it.
Excellent, thank you. And Peter, can I ask you the same question as well, please?
Yeah, well, when this all kicked off, everything went really quiet in respect of patient contacts. And we've seen it creeping back, and GPs everywhere are engaging, particularly over the phone and video consultations. But there's a group of patients that actually I think we're not seeing, tending to be older people, chronic disease. How do we re-engage with these patients? How do we get back on top of helping them through their medical conditions? So that's one of my interests. And then I'm also into horizon scanning. When this is all over, please God, what are we going to learn? How is it going to have changed GP practice? How can we prepare for that? Particularly our more junior members of our profession, the associates in training and GP trainees. What messages do we need? How do we have to prepare them?
Excellent, thank you very much. And Joseph, I think the situation in Spain is somewhat different from where we are in the UK in terms of the tightness of the restrictions you're facing. So perhaps you could just give us a quick introduction of how you're managing things over in Spain at the moment, please.
Okay, we have been strictly locked down, and now these restrictions are decreasing, but it varies depending on the areas. Madrid, Barcelona, the big cities were highly populated, are strict, still under a lockdown. I have restrictions to move, and an overall restriction in all Spain to remain into the same province. But in rural areas, there are no restrictions to move during the day. And what I can tell you is that even it is compulsory to wear a mask on the streets. The Spanish government issued a law last week. It is compulsory to wear a mask everywhere in public areas and mainly in the public transport. There are people who follow this recommendation and people who do not. I think it depends on whether, how close have you been to the coronavirus. If you had a relative, a friend, a close friend, or even yourself had the coronavirus, then you adhere to the restriction, to the law, and to the recommendations. If you do not, this is just something that is not with you, and you don't, perhaps you don't adhere so much. But in general, what I can tell you is that restrictions were very successful. I can tell you that since yesterday, there were 0 cases in Catalonia, 0 new cases. And even in Spain is one of the countries with the highest number of cases worldwide. But the restrictions, fortunately, were successful. And now the epidemic is clearly decreasing.
Okay, excellent. So thank you for that introduction there. So I think one of the messages that we've been hearing in the media recently is that general practice is open. And that we're very conscious that we've had a number of patients that have been doing as they were told and staying at home, not trying to overwhelm the NHS, but that's meant that there's probably a fairly big backlog of work out there. Lawrence, do you have any particular concerns about how we're going to manage in a practical sense when that sort of stored up workload sort of comes to the front again?
Very much so. In Northern Ireland, we still have QoF. I know there's variations in contracts throughout the country. And previously, in the 1st of April, we would have started to work through our diabetic population. But things are different now. We can't just routinely work from the patients using A to Z of their names. So what we're doing to ensure patient safety is to identify the ones that will be most at risk. These are the diabetics who are most at risk with high HbA1cs. And similarly then with our hypertensive patients. In our own practice as well, we're going to start looking at our younger asthmatics and maybe send out for them for remote consultations using the various apps that we can use for our surgery. So it's more rationalization, to try and identify those who need the care the most.
Okay, excellent. And obviously, it's as true in Northern Ireland as it is elsewhere that we've been using lots of new technology. So we've got lots of new tools at hand. Have you considered how you might be able to use those in terms of long-term condition management? And we seem to be very well geared up at our end of the consultation, if you like, within doctors' homes and surgeries, but maybe our patients don't have the same access. So have you got any thoughts about how you'll be dealing with that sort of within your practice and within Northern Ireland?
So it is very difficult, and you're right. I mean, we've managed very well as GPs, you know, to use things like Accurix and so on, but some of our patients don't have those things, and we need to be mindful that some people do not have the same access as we do. All of our initial contact with the surgery is through telephone triage. So the telephone triage needs to be very aware of what abilities that patient will have.
Okay, excellent. And Joseph, how common was telemedicine and the use of technology in Spain before COVID, and how have you found it? And do you see any advantages as you emerge from your lockdown situation in Spain?
Well, telemedicine before COVID was quite uncommon. And telemedicine now is being implemented everywhere. Well, actually, I can focus on Catalonia and Barcelona. That's where I work. And in my practice, now all computers have a webcam, and the system, the integrated clinical record, we have a single electronic clinical records for all Catalonia. Now the system allows all family doctors, all GPs in all Catalonia to have a teleconversation, to use a webcam, to have a conference with their patients. If the patient, of course, has a webcam and the computer. So it seems that telemedicine is going to be implemented very fast, and probably there is no way back. It's here to remain, probably.
Okay, and how acceptable has that been to your patients? Have they embraced the new technology?
Well, to be honest, so far I didn't use with my patients yet. So I'm using the telephone, the phone calls, and so far I didn't have the opportunity to test how the system works. I just used with colleagues, to communicate with colleagues, to exchange experiences. But with patients, it's not so easy. And mainly our patients are need, as Lawrence pointed out, hypertension, patients with hypertension, diabetes are in general quite old and perhaps not so prone to use the new technologies, are not familiar with computers and so on. So I think in the near future, we will use more and more, but now it's still too early.
Okay, thank you. And I think one of the common themes that we're hearing a lot about as we're going through this exit phase is the importance of evaluation of these new methods of communicating with our patients. And Mohan, I imagine that's something that you're very interested in, with your interest in sort of patient-centered care and personalization of care. Perhaps you could just explain a little bit more about your role as one of the ambassadors for that work, and your feelings around the impact that the new ways of working is having on that and continuity.
Yeah. So certainly, as we are exiting the lockdown in COVID, we are seeing a lot of psychosocial cases. So patients who have been locked up for long periods of time. We're social animals, and we need to be out activating or seeing other individuals. And if we don't, that will affect our health and well-being. So we're going to see quite a big curve, or quite a big surge of cases where people are suffering from mental health well-being. Lawrence alluded to that with his depression and long-term conditions. And I think it's really important that we use our enablers to help support that. So we've got plenty of those. And I think touching on access, that was previously not utilized before, but now that using telephones and using video consulting, that can reach people who we've not been able to reach before. We've been able to reach some of the shielded patients, some of the isolated patients who do have the technology. There are obviously those patients who don't have that technology. And I think some of the enablers around shared decision making. So what really matters to an individual, using social prescribing, so mental health and wellness. Patients are being really isolated, how they can support each other, what exists in the community, which services are still around. And the link worker for us has been paramount and massive in terms of being that sort of link between the practice and the community. They've been working remotely, but they've been able to work through their shielded list of vulnerable patients, those patients who are not quite shielded but actually need extra support. So I think these are some of the new ways of working which have been key in order to help support person-centered care. And actually we need to remember that a lot of people have been locked up and they've been reflecting on their life, and actually they're ready for change. And so we need to move with that change and also listen to what the patient wants to do and adapt to that.
Excellent. Okay, so I think there's a really strong message there, isn't there, as we're emerging from from lockdown. It's not just about the way we want to practice, it's about what sort of medicine our patients want to receive and what matters to them. We've actually had a couple of questions in from Twitter now. The first one is there an opportunity to educate patients to self-manage with minor problems and therefore focus primary care to those with the greatest need? Now, it strikes me that we're going to have some capacity issues. We're hearing lots about the capacity issues in hospitals because of the challenges around staffing, social distancing and PPE. And those challenges are going to be just as real for us in primary care as well. So maybe I can come to you, Lawrence. What do you think about the opportunities to educate patients around self-care?
Very much so, and I think it's going to be very important. But also that we have to do this as a system. This can't just be GPs doing it. So it's going to have to fall to national governments as well, as hospital colleagues, as GPs as well, as about how we access our services, what that looks like and what our responsibilities are. Unfortunately, we won't be able to see people as quickly as we can, but again, that comes back down to prioritization. We need to see those at most need first and then work our way through as best as we can. But it's important that the public realise that and come with us on the journey. I mean, I think they did very much so at the start of the pandemic. I mean, the record low numbers at casualty departments and so on, and I think they will again, but it needs to be a joint campaign together.
Yeah, and I think there can be a fair bit of tension around that, isn't there? So what we might be calling prioritisation, others might be called rationing, and that is going to be a consequence of the fact that we perhaps don't have the capacity. What sort of discussions will you be having with your patients, Peter, about their ability to access sort of either community services or hospital services, and the fact there may well be a delay built into that?
Well, we come from an area where there are already longer delays than many other parts of the UK. But I think that just going back to that last question about self-management, we've seen a major reduction in the early part of the pandemic in patients accessing GPs and A&E, and a much enlarged involvement of NHS 111. So I think NHS 111 is going to play a very important role across the UK. It's in different forms in the different countries, but I think it's going to be encouraged to be an initial point of call to direct patients for self-management, because it's only by trying to reduce the demand that we're going to have any way of getting on top of the backlog of patients, because let's face it, when things do get moving, we are going to have reduced capacity. We're going to have reduced capacity because we're going to have to do social distancing in practices. There's going to be social distancing in hospitals. There's going to be different ways of patient flow through both services. We're going to have clean clinical facilities and potentially hot clinical facilities. So we are going to have to work a lot smarter than we have done. And I think we're going to have to prioritize different groups of patients to make sure that we don't build up increased adverse outcomes.
Okay, and Joseph, how is that sort of taken on board by patients in Spain? What sort of waiting lists would you have normally, and do you think you'll have similar trouble there as you exit, and perhaps you can't see as many patients as you usually would, either in your community facilities or in your hospitals?
Well, we reorganized completely the way we work, and we organized our practice as seeing emergencies and with a clear distinction between potentially infected or infective patients versus non-infectious or non-potentially infective patients. And we have just a new system of working in which half of the doctors in the practice and half of the nurses just practice phone calls and telemedicine, and the others work face-to-face with the patient. There is a challenge with waiting list in the referrals to the hospital, because the hospital is also locked down. A challenge in the tests. Blood tests have been unavailable. Routine blood tests have been unavailable. X-ray have been focused on chest X-rays for respiratory infections. And so far we are working in a completely new way, an abnormal way even still now. How will we deal with chronic patients? Now we delegate much of the work to nurses, and nurses start to call patients, and some patients are appointed to the practice. But in Barcelona city, the risk of infection is still high, even much lower, but still high. How long will we be working this way? I don't know. This is a challenge. So yes, our patients want to see us. Our patients are anxious. Our patients need our calls, need to speak with us. And I don't have a clear response how we will manage this. I think that now we are just observing if there will be a second wave of infection or not.
Okay, that's lovely. Thank you, because we're absolutely right. And we need to be mindful, don't we, that we're exiting into a pre-vaccine era. So we've still got the challenge. The virus is still present. We still don't have a vaccine. So we're not out of the woods yet. And the potential for a second lockdown is there. And I guess that's something we might come back to later. Mohan, I just wanted to ask you, we've talked about different ways of working, and I know group consultations is something that has been suggested as a way of sort of building community resilience. I just wondered if you had any views on that at all.
Yeah, no, definitely. I think what's been astonishing in this COVID time is how the community has come together and how people have come out and really grouped together and helped their neighbours and helped support each other. And there's been a mass number of volunteers. So the NHS volunteer scheme has picked up a huge number of volunteers across the country, helping to deliver medications and deliver objects to particular patients. So that's one example. I think we can really utilise that as an asset. You know, we as a GP practice are part of the community, and if we can support our individuals who work in or live around us, I think that can take things forward. Group consultations. We've actually got a volunteer, Merton Mutual Aid, who are helping to support our individuals, and they're based around wards around the practice. And we are providing webinar. I'm doing a webinar after this at 8:30, and that's about to give them educational part of what's happening in healthcare. We're also going to do a talk on domestic violence and also mental health and well-being as well. And that's aimed at the public to see firsthand about what actually is out there and what are the real details. There's a lot of stuff on social media, a lot of stuff on Google and in the papers about good and bad stuff. And I think, you know, us as leaders, if we can provide that for our community, I think that's really empowering, and that will help build their resilience. That can touch a few people, that will then pass on to their community, and also the word will spread. So I think group consultations is certainly the way forward, and Rupert Jossie has been doing that in north of London, and also Ellen as well, one of the other regional clinical leads. And I think actually this is certainly the way forward, something we should take forward, definitely.
Excellent, thank you. And I think we've had a question come through Twitter again saying, going forwards, will single GPs and smaller surgeries be able to cope with these new ways of working? I think, Peter, you work in a relatively small practice. Would you be able to give us a view on that?
Well, yes. I mean, countries like Wales, we've got a lot of rural practices which are fairly small. We've got inner city practices, some of which are still single-handed. But I'm positive about this, actually, because I don't think it's the size of the practice that will determine the new ways of working. I think it's going to be the attitude and the support of the GPs who are leading that practice. And for smaller practices, I think these new ways of working offer an opportunity to network more closely with their colleagues, both in neighbouring practices and in hospitals. An opportunity to work in ways that are more amenable to being a practice where you've got a low number of clinicians. So, you know, working from home, for example, and a way of reaching increased numbers of patients in a more acceptable way to them. So I think it's down to leadership and support. And with that, I think small practices and large practices will embrace these new ways of working.
Excellent, thank you, Peter. Joseph, I just wanted to pick up on something you said earlier on. I think you said that you have totally joined up clinical record for both primary care and secondary care, and you can see that right across Catalonia. Did I hear you correctly?
Well, we have an intermediate, a shared clinical record. We call this way a shared clinical record of Catalonia, in which all data coming from primary care is uploaded into this shared clinical record, and most of the discharge reports from the hospital, public hospitals, complementary tests such as IPRACE, blood tests, and so on are also uploaded. So actually, there is a shared clinical records between hospitals and primary care. Not only one practice, a single practice, but also the practices all around Catalonia. So this system is evolving, and more than that, even the patient himself can connect to these shared clinical records and can observe the results of blood tests, results of IPRACE, the diagnosis in the primary care records, and so on. So yes, this is perhaps the big project of the Catalan government. Yeah.
So I mean, that sounds as if you're a little bit further ahead with that than we are in certain parts of the UK. But it's certainly something that we've done locally. I work in a fairly large practice, and we operate across 15 different sites with various patient lists. But we've got it now that we can access patient records from any of our branch surgeries and from any of the other patient lists, which has helped us greatly when we've had either branches shutting down or we've had big cohorts of the workforce of been taken out or have had to go into isolation at the same time. Have you got any experience of that in Northern Ireland, Lawrence, about sort of being able to access other records from other practices, just a way of building in resilience? And are there any other ways that you've built resilience into general practice services over there?
Yes, so in Northern Ireland we have federations. I think maybe in England you have clusters, and federations have really come to the fore in the COVID crisis here in Northern Ireland. One of the things in Belfast and West Belfast and in North Belfast, practices quickly got together and matched each other with clinical systems, so that if there was a risk of one practice going down, there was good support between practices. And those federations were really helpful in fostering support with each other. And actually, education really came to the fore throughout them. So we all learned from each other. We all brought in speakers from secondary care and learned together as a team. So it was a real effort together.
Okay, thank you. We've had a question in that's actually directed towards you, Lawrence. It's asking, how do we use telemedicine in Northern Ireland, where Accurix, which is one of the video platforms, is incompatible with the Vision clinical software? I guess we're always going to hit glitches with any sort of technology, but is this something that the college is aware of and you're working on?
Yes, it is. So we are aware of this particular thing. So Accurix doesn't work with EMIS, or Accurix works with EMIS Vision. It only works with Zoom at the moment, and there has been a few wee quibbles about security with Zoom just at that particular instance. But the board has a clear letter on its website, and I'm very happy to take this forward with this GP, and get a few answers for him. But generally in telemedicine for Northern Ireland, so the College in Northern Ireland has done a survey asking about patient or GPs' access to their clinical systems. And we find, that 60% maybe do have some access. There's 40% of GPs still don't get good access to the clinical systems while working from home. So we're using that and other things to help our government, see the potential benefit of investing in telemedicine and technology for GPs in Northern Ireland.
Okay, thank you. I think one of the other benefits that come out, and I think Joseph, you touched on this earlier on, was the fact that you're able to have communications with your GP colleagues in Spain, but also with secondary care doctors. How's the relationship between hospital doctors and primary care doctors changed over the last few months with everybody working differently? Have you seen an improvement in relationships with your secondary care colleagues, or were they always quite good anyway?
Well, I think the relationship with secondary care is in general good, and was in general good before the coronavirus. And now, after the epidemic, of course, everything is impaired, and perhaps we use direct contact, mainly emails or phone calls, WhatsApp or whatever. So actually, yes, perhaps the communication improved, but to be honest, I must say that before coronavirus, the relationship was pretty good in general. It depends mainly on location, where hospitals are located, and also it depends on persons. I mean, we at the end we are human, and depend in our human relationships on our attitudes, in our beliefs, and how we see the others, how we see the specialists working in the hospital, how they see we GPs working in primary care. But yes, the coronavirus had an impact, clearly.
Excellent, thank you. And Mohan, perhaps if I can direct that question to you too, because you've talked about how we need to change relationships with our communities, and how indeed we've seen changed, activation within communities. How have you found relationships with your secondary care colleagues as we've tried to go through this period where they've been exceedingly busy in the hospitals, we've been exceedingly busy in primary care, but we haven't had those usual routes of referral open, especially for the routine things. So how have you found relationships with your consultant colleagues and accessing that expertise when we need to invite that into the patient pathway?
Yes, so I think initially it was a challenge because we were all trying to find our feet in terms of how the new way of working was within our own environment, and then that cross-working between the two areas as certain services did close their books, but now it's evolved into a nice way of working, and I think we have lots of hot clinics, or hotlines, I should say, so telephone lines. So for children who are suffering from COVID, there's a paediatric hotline, so we can call them and get some advice through the consultants who've had their, sorry, the light's just gone off, who've got paediatric helplines, so they can give them some advice over the phone because some of their clinics have closed down. The same thing for geriatric geriatricians. They've also had geriatric hotlines, so we can contact them for some advice over the phone. We can also email them through a service called Kinesis, which has been very helpful in terms of getting patient contact or identifying some results or a care plan for an individual. So I think it's certainly changed, and I think it's something which we're trying to restore back now as services are starting to open, and certainly as the NHS is starting to get some of their normal services back.
Okay, so I think one of the challenges as we go forwards is not to go backwards to just resuming everything as we did before. But I think we've acknowledged earlier on in the discussion that there probably is going to be a fair backload of work, some of which we'll know about already, but also probably a whole load of hidden work that's out there. In really practical terms, at your surgeries, if you're trying to maintain social distancing with other members of staff, and we've got the use of PPE, and we're not going to be able to consult at the same speed as we have previously for all those practical reasons, how have you redesigned your surgeries in order to keep up patient flow as best we can? Perhaps, Mohan, you look like you're sitting in your surgery with someone staring over your shoulder, so perhaps you could start.
It's turned dark, the automatic light's gone off. Yeah, so how general practice changed, and and certainly overnight, we're all using a telephone triage model. We're consulting everyone over the phone initially, so we have a single list. All GPs work off that. And what's great is actually we all stop halfway through mid-morning and we meet for a coffee. We've never been able to do that before. We've all been kind of in our little caves, and when our clinic's finished, we then go off and do our own thing. So I think that's been massive in terms of being able to change things and help with our morale. I think going forward, how we can support how things are going to affect, I think part of utilising our staff is going to be key. So it's not all down to the GP. I think, can we deploy AMPs? Can we deploy social prescribers? Can we deploy other paramedics to go and do some of the visiting? So I think it's utilising our different healthcare professionals. That's really come to the forefront now, and we've been able to use our full array of healthcare workers to help support that, and that's what we're starting to activate. We're also working across practices in our networks as well, working at scale, and I think this is where it's really comes to its own. I think we can help support each other in our own areas.
Excellent. And perhaps, Peter, I could ask you the same question as well, because I'm guessing you're working in a slightly different setup to Mohan. One around the utilisation of the broader workforce, but also any challenges you faced as you started to turn things on in a practical sense. Can you flow in through one door and out of a different door? Is that possible with the buildings and the estates that you have? And any other comments you may have got from colleagues in Wales?
I think, Gary, you've hit on it. Estates is the key, and I think different practices have different capacities. So we are sort of quite fortunate in a relatively modern building, and like this week we've been looking at how we're going to manage the patient flows through the building, and what we do with the toilets, and what we do with the seating, and who goes where, and we're already my practice is run out of a health board owned health centre, so we're looking at getting additional rooms to try and build in some additional capacity. But then, you've then got to think ahead about like what are we going to do for the flu season, the flu immunisations, How can we use car, you know, people arriving by car? We're trying to get around different angles to this problem, some of which is estates, some of which is our staff, some of which is thinking of working in new ways. I mean, one of the things which are, we have clusters in Wales, which equals sort of mini networks in England, and so, you know, as a cluster, do we band together and start using additional premises to do things like the flu vaccination program this autumn, to pool some of our services like chronic disease management and so on. So it's exploring all sorts of different avenues. And I think one of the things that GPs are very good at is that we are versatile and nimble, and we can spot new ways of working. And I think that's the key of succeeding in the new environment.
And I think we were talking earlier on, Mohan, about how we, you know, what would have been seen as unacceptable maybe 3 months ago is much more acceptable now. I think you were talking about perhaps drive-through flu clinics. Is that something that you're seriously considering?
Well, like we talked about the social distancing rules, I think if we need to provide vaccinations for, I mean, for the immunisations for the young children, it's quite easy because they're lower numbers. But for a big cohort of flu vaccinations, you know, we can't have the old days where we open up on a Saturday or evening clinic and we pile everyone in. You know, those days may not be here for August. So we need to think of other ways of working, as Peter was saying, and I think that would be an option we're exploring really, you know, in Merton, is can we do a drive-through, can we get in a state where, you know, patients will come in and come straight out, and that will work with our networks or clusters, as practice can make that, you know, per arrangement, our practice or network sizes are big enough to make that happen. So that was just one example.
I mean, it certainly seems, doesn't it, if you throw a particular challenge at GPs and they have an opportunity to collaborate, they're given a bit of time, a bit of space to do things slightly differently, they come up with really ingenious ideas. I was talking to one of the other guys, he's the honorary secretary at the college, Jonathan Leach, who's got a military background, and some of the sort of military techniques for planning the flu clinics. But we are going to need military-like precision to get through some of these logistical challenges as we move forwards as well. And quite often it will be giving people permission to try things differently. You know, the growth of WhatsApp groups and people communicating through those sorts of forums is something that we've done as well. And certainly college last year, we were looking through our future vision work and our technology manifesto and roadmap as to how we sort of give people permission to use these new tools that we've been given. And at the time, we wouldn't have dreamt at that stage that we'd have got as many laptops, as many webcams, as many different software licenses out into primary care. So I think we're using the technology to deal with a particular challenge at the moment. But Lawrence, going forwards, can you see any other areas where we could use these new tools to do things differently?
So in Northern Ireland, we already had a plan about multidisciplinary team working and so on. And Mohan had mentioned earlier about how he finds his key workers so important and so helpful. And what we are seeing now is this tsunami of mental health work coming down. So it's thinking slightly differently in Northern Ireland, where we're trying to provide more of the patient care in the community in their surgeries. And in my own practice, we've recently had a mental health practitioner as part of that MDT model applied, and it's just been a revelation having that person in the building next door to my surgery who's acting as a proactive care worker. So she's phoning up people who are already on our mental health list, and she's checking in with them. So, for example, people who have, like I said, there hasn't been increased rates of schizophrenia, but people who have schizophrenia are suffering with this with the lockdown, and she's able to link in with them to help them, to get them back in their routines or a different routine that supports them, and that's just been so refreshing. But again, other things that think differently, like we've been talking about how to do flu clinics. We have practices who are purchasing gazebos to put them outside the surgery, you know, to do minor dressings or blood tests and things like that. So it's that adaptability that dental practice is just great for.
Okay, so I mean, we've heard of a couple of ideas that, you know, one of the joys of these sorts of discussions is by bringing people from different places around the country and indeed internationally this evening, that we can share these ideas. But we often reinvent the wheel, don't we? You know, even practices 200 yards apart down the road. So how do we go about making sure that we learn the positives that come out of this? And maybe, Joseph, I could ask you, in Spain, do you have any mechanisms for sharing good ideas and new ways of doing things that that you think work particularly well and perhaps we could learn from in the UK?
Well, mainly we have internally, we used to meet the full team of doctors and nurses every week, several times. Now with the coronavirus, it's impossible to have face-to-face meeting, but we have started to meet online, like we are doing, using Zoom, even if we are colleagues and we work in the same place, but we do not meet all together, but we use Zoom meetings or using other softwares to share ideas, to share experiences, to update protocols, and so on. Between practices, using our colleges, using our societies, using our associations, and between regions as well, using associations, and internationally, we use also other networks. Our organization, Wonka Europe, recently organized a webinar jointly with WHO this afternoon before us. This way, with meetings with colleagues, with scientific societies, with papers, with blogs, with posts on the internet, Twitter, Facebook, whatever. This is the best way we share experiences. I appreciate a lot to be here because I can hear you and I can hear how is the situation in the UK and in the nations within the UK, and how you work differently, rural, urban. So I think this kind of experiences can be of use for doctors across Europe. Yes.
And I mean, I think we're certainly finding with our internal workings at the college that we have meetings that have become much more inclusive now, because anyone can join on and jump onto a Zoom call from wherever they're based. And it's allowing us to bring together expertise and knowledge from around the patch. Are you finding that within your networks as well, Mohan, perhaps with the other person-centered care ambassadors that are trying to replicate what you're doing in London elsewhere? And are you finding these new ways of working outside maybe the clinical role, but in terms of information sharing and spreading of good practice?
Oh, definitely. I think communication is absolutely key. And actually, before COVID, we weren't using webinars. Well, we weren't using as much as we are now. And certainly the idea of having a meeting like this through the computer would have wouldn't have appealed at all. But now actually you can get a lot more out of it. While this conversation is happening, you can put your comments on the comments box, or while you're not actually activating, you can still contribute, which often doesn't happen in a face-to-face meeting. So I think it actually gets more, you get more enrichment. And I think the worry is how we're going to switch back to coming back to meeting face-to-face. I think it's also more efficient in terms of we can have more meetings in a day, and actually we can share good experience and actually link up with other people in other parts of the country. So I think definitely it's really helped drive that through, and I think that's certainly something which will stay and show some great benefit. I think the webinars in particular, I've been to some webinars where they've had 200 people, 300 people on it, which are amazing and really been thoughtful. And I think Nikki Kanani ones were up for 1,000. So really good way of getting information across. So definitely.
Excellent. And perhaps, Peter, can I come to you and ask you in Wales, what sort of networks do you have there for sharing information, especially across, I guess, some of the more rural areas?
Well, we've got the clusters in Wales, which are based geographically, usually about 20 to 30,000 population. We've got a very active online group of RCGP members, and that's really been great because it's flagged up issues that have arisen because of COVID. For example, one was problems with the NHS website in Wales, indirectly directing people. Another one was what's going to happen about the trainees' exams when it's a predominantly Welsh-speaking area, when they have to produce videos for the RSA. So it's been very effective, our online group, and the local groups have also been very effective. But from the macro side, I'd like to move to the micro side. And Mohan earlier talked about having time for a cup of coffee. That seems to be happening in so many practices that we're actually probably communicating with each other a lot better than we used to, because we're finding time to do this. Because another thing was when there was the start of the pandemic and there was the slackening off of patient contact, it allowed us to talk to each other and to work out what we needed to do and how we were going to do it. And we must be really careful, I think, not to lose that as time goes on. These are really important things that we need to take forward.
Absolutely, and I don't think you get argument from anyone on the panel that we really have to protect that time we'd carved out and it was only for a couple of short weeks, wasn't it, that the workload really dropped down. And I mean, certainly true anecdotally from all the people I'm speaking to, that workload's picking up again, and that's shown through the Research Surveillance Centre, which is the RCGP workload observatory, that the figures are picking back up to nearly pre-COVID levels. The other thing, of course, that we saw drop off at the start of COVID-19 was a lot of the unnecessary or disproportionate contractual and regulatory administration and bureaucracy that we face usually as GPs. So in terms of sort of CQC inspections, the fact that appraisals were held up or postponed. Do you guys have any views around that, sort of more of a policy level? Lawrence, perhaps I appreciate the contractual elements are slightly different in the devolved nations, but perhaps is there anything on a policy level that you're campaigning for in Northern Ireland that the membership would want to hear about?
Yeah, so we have slightly different things. So we don't have CQC here, but like you, I mean, we've very much welcomed that appraisal has been paused and things like that, and the reduction in sort of paperwork and admin associated with QAF and leses and so on has been very welcome. And we're very keen, that, like I say, quality has to be done and we have to do the right paperwork. The things that we're focusing on is we're working with College Centrally to see, is there anything we can do with things like appraisal? And also we can talk to our GPC colleagues to talk about QAF and contracts and things, but there's no plans for that at the moment. All that we're doing at the moment is just trying to focus on the priorities with it.
And I think one area that we're talking a lot about at the moment is around appraisals. And for a lot of doctors, the actual conversation they have with their appraiser is really helpful. But it's quite a burden drawing together all the evidence beforehand. And, I know what I'm like. I promise myself at the end of every month, I'll do a bit towards my appraisal. And then 2 weeks before it comes to the appraisal, I spend a whole week of evenings getting things prepared for the 2 or 3 hour conversation. And there's some really good work being done suggesting that we narrow that pre-conversation work right down to the bare minimum, but still allow people to benefit from the discussion that they're having with their appraiser. So, and especially as doctors and our teams emerge from the challenges we've been facing, a focus on well-being and allowing it to be about personal development and personal well-being is something that I think as a college we want to get behind and support. Do any of you have any feelings around that? I can see Mohan nodding, so perhaps you'd like to comment around how you think we could restructure appraisal or some of the other bureaucracy that we're facing that we really don't want to reintroduce as we exit the current scenario.
Yeah, so I've just done my appraisal about 2 weeks before this all started. So, I think it goes back to person-centered care for me, and even individual-centered care, and it's actually what matters to an individual. And I think we have had so much time to reflect about what do we actually want. And I think while appraisals were there to help support professional development, personal development, I think it also that a lot of those have changed now. And I think if we can look into that and identify what your targets are for the next 6 months or 12 months, and actually you can reach it in yourself to make that happen. I think if we can have some guidance around there, health and well-being is so important, and actually strive towards that. I think that would be really helpful to add in future appraisal, definitely.
Excellent, thank you. So we're still sort of within the policy arena at the moment, and I think Peter, you acknowledged earlier on that estates is an issue that we face in general practice. On a policy point of view, is there anything that the RCGP in Wales is campaigning on at the moment, or something that's rising up your agenda that you think is important to share with the wider membership, and just hopefully will define the way we can do things moving forwards?
Well, one of the things we're working on at the moment is e-prescribing, because we haven't got that in Wales. It was rolled out in England 3 or 4 years ago, I think, although I know there have been several iterations of it and it's by no means perfect. But we'd been approaching Welsh Government for well over a year before this, saying that it was really important, and not been really received very well. And then the pandemic struck and many doctors were working remotely, and we were having problems getting stuff to the pharmacies, and it would have been absolutely perfect had it been in place. But we're now getting a sort of almost a sort of tidal wave of support for this. There's been a petition launched for its introduction. We've had meetings with Welsh Government and NHS Wales, and it's rather a case of how quickly it can be rolled out. But it's a case of that's a good example, I think, of how the college works well, because we've got sort of college, if you like, leaders with an idea, and then college membership, the profession supporting them and producing a sort of political force that drives change. And I think you can extend that to other issues like the estates. I mean, many parts of the UK GP estates are very poorly resourced, and I think we need to come together to create that political will to change that, so that we're better placed to deal with maybe the next problem that we have, but also dealing with getting ourselves out of this current issue with the backlog of care that's going to be needed.
Yeah, and I think you've hit the nail on the head there. One of the advantages of college membership for me is always that balance between the power of the membership getting behind a cause, and then the policy angle that the leadership of the college can take to really influence things. And I think we've shown over the course of the last 3 months that our relationship with the external bodies like NHS England, with the BMA, with the GMC, and with the Department of Health and the government has really made a difference to both the investment in and our ability to deliver care to our patients under the really most difficult of circumstances. I'd just like to sort of tease out some more questions now around, we've seen a lot of change, and as we move forward, I think the temptation is, if we hit blocks along the way, that we'll be tempted to go back to doing things in the old way. If you could just pick one thing that you've seen change in your practice, Mohan, over the last 3 months. Now, you've mentioned getting coffee in the middle of the morning and the different ways you're working, but what's the one thing you really want to hold tight of in terms of something that's made a huge difference to the value add to your patients?
So for me, the collaborative working, I think working together and working out what roles of really exploring and maximizing what our other support workers can do. And I talk about our paramedic going out and doing visits. I talk about our link workers doing their linking with the community. I talk about the coffee mornings. I think the accurates and the opportunity to improve access for individual patients, and also for doctors themselves as well. I think those are the key things I would want to keep hold of, and I'm sure we will keep hold of going forward, definitely. Okay,
and Lawrence, how would you balance sort of these remote consultations we're doing now with what we used to consider the gold standard of face-to-face? We saw a massive shift literally over the space of a weekend, but as things start to move back to perhaps people being more accessible to their doctors or happier to come and see their doctors, how do we maintain that balance so that we don't swing too far back in the other direction, and that we keep a forward momentum? How do you think you're going to influence that in your leadership position in Northern Ireland?
So it's very difficult, because what we frequently mistake is the difference between telephone triage and telephone consulting. And they're quite different, and telephone triage does enable us to get the right patient into the right place, whereas telephone consulting, as we know, is remote working, and it's a different way. With our MDT model in Northern Ireland, we could see that telephone triage could have huge benefits. We're pushing hard with government, and we're lobbying very hard to get MDTs into practices. But quite frequently, what our members were saying to us is that whenever they had triaged a patient, they literally had nowhere else to put them. So having other members of our multidisciplinary team means that if somebody phones me up with, say, back pain, I have a physiotherapy appointment slot that patient in rather than the old way. Whereas if I did a triage, I had to see them myself again, so there wasn't any benefit in triage. So inserting the multidisciplinary team in our practices would make huge benefit.
Excellent. And I know that prior to COVID, you've done an awful lot of work with the relationship with secondary care and produced some fantastic materials that is used across the UK now. But where are you in terms of that work now, and how do you hope to take that forward through the next 18 months where things are going to be difficult because of capacity issues? And I think communication with colleagues across the spectrum is going to be really, really important to the success of making sure our patients get good quality healthcare.
Yeah, so it's already taking effect and it's already become used. So in Belfast, one of the hospitals has set up a surgical assessment unit, and some of the surgeons that we worked with on that document right from the start said to their colleagues that we must be courteous, we must be respectful to our GP colleagues. There could be no such thing as an inappropriate referral. Everything must be considered as equals and as equal colleagues. So that was great to hear that from the inside, as it were. But it also gives us a document going forward that if there's going to be, let's call them transgressions between one side or the other as who's responsible for a piece of work. And if there are those sort of debates, it gives us a piece of agreed work that we go back to. The document, which is on the website, if you go into the Northern Ireland section and into our documents, you can find the document there. It's not just a GP document, it's owned by all 14 colleges. So there are a set of standards that we've all agreed together. So if a surgeon or a pediatrician, if there's a dispute between GP and pediatrician, for example, there's things there that we've agreed to together that you can go back to. But it's on the website. If you go into the Northern Ireland section and go down into our document, you can clearly find it there.
Excellent, thank you. And perhaps, Joseph, if I can come to you, we're coming towards the end of the discussions now, but you were saying when we had a chat before we started this evening that you're still under fairly strict lockdowns. Which element of your normal working have you missed most? Which bit are you looking forward to perhaps getting back to doing something a little bit more resembling what you did before?
Well, I miss the face-to-face contact with my patients, obviously, and not only for medical reasons, just for psychological reasons, for both patients and me. And some colleagues say that there is no way back, that life will not be the same after the coronavirus, that telemedicine is here to remain, and that the new practices such as better use or a massive use of phone calls in our day-to-day practice will remain, and that perhaps doctors could do other activities. So at the end, I enthusiastically support telemedicine, phone calls, and new ways of working, sharing information, whatever. But at the end, you know, I'm from a southern country, from a Mediterranean country. I miss my patients.
Yeah, and I think that's an absolutely great sentiment to bring tonight's discussion to a close. Again, the hour's flown past, so I'd like to say thank you to the four of you so much for joining me this evening, and all of the people out there that are watching this either live or on catch-up on YouTube. I say this is the third in a series of discussions that we've had. The next one is on the 17th of June at 7 p.m. and that will be led by our Scottish Council Chair, Carrie Loonan. And that's all about health inequalities. Again, we've got a great panel lined up to have those discussions with her. You can already start asking questions for that discussion through the hashtag RCGP Together Live, or again through our online members forum. But I think my reflections on this evening, we've been through a really difficult time individually as people, collectively as doctors, and that's been reflected in the challenges that are faced our patients as well. But I think we've been given some new tools to use. We've perhaps been given new methods of communicating, and more importantly, a different mindset, a more permissive mindset. And I'm really excited about perhaps being able to develop new ways of working. So that's it for this evening, but I'd like to thank everybody that's joined us this evening for this discussion, and really look forward to joining you again next time. So thank you all, and we'll speak to you again soon. Good night.